First of all, thank you very much for the love, the recognition and the award. And a very special thanks to Dr. Pratap Jatwani, my dear friend, for this opportunity and the invitation. And I am deeply indebted to RSSD Gujarat chapter for this incredible recognition. I am happy because of two reasons. Number one, it is a recognition from our own RSSDA. And thanks to the Gujarat chapter, all the members, Dr. Akash, Dr. Soni, Dr. Sushil, Dr. Sanjay Phadak, and all the friends at Gujarat chapter. And the second reason why I am so happy is this honor is in the name and in memory of, this is not moving? Okay. And in memory of Dr. O.P. Gupta, whom I respect a lot. I had multiple opportunities to interact with Dr. O.P. Gupta, a visionary leader. And this is a picture when he is awarding me the oration at Dr. Benshi Sabu's Daycare Con, and that was way back in September of 2018. And I respect him because of many reasons. Number one, he is the founder president of our RSSDA, and he chaired the first EC meeting of RSSDA. And even beyond retirement, I believe that Dr. Pratap Jatwani was stating that in the introduction, he used to be very, very active for more than 3 decades, even after retirement. Very active in all the academic programs, in practice as well, and in research. And very much honored to deliver an oration in the name of this visionary leader. And with this, let me move on to the duty which is vested upon me by Dr. Pratap Jatwani, and this is sharing my journey with telemedicine in diabetes care over the past more than 2 decades. I don't have anything specific to disclose pertaining to this oration. This is an AI generated image. And in this AI generated image, you see a physician over there. Obviously, he is not happy. And this image is representing you and me. And this image is representing a doctor who is probably not that happy, probably frustrated. In the last more than 10 years, more than 12 new drugs, there are injectables, new oral medications are there for diabetes. The science is advancing, the research is advancing. But let me ask you a question. Are we happy? Are the doctors happy with the outcomes in diabetes? Of course not. And that is one of the reasons why we are gathering for conventions and conferences to fill in the gaps. And that is one of the duties of RSSDA. Many national leaders are here, Dr. Sunil Gupta, Dr. J.K. Sharma, so many leaders in RSSD are gathering almost every week. We are in some convention or the other to fill in the gaps. The numbers are increasing. The numbers of those with diabetes is increasing. And the non-communicable diseases are responsible for more than 70% of deaths worldwide. And 3 in 4 people with diabetes, they live in low middle income countries. And organizations are sensitizing the young people, the young doctors. There are multiple programs, and Rudil is leading one of such major initiatives training the young doctors in the country. But the barriers are still prevailing. If you look at the low middle income countries, this is the statistics. If you delve into the deeper aspects of diabetes care in our own country, it's only 36% of those with diabetes receiving the treatment. The rest are not even aware, they are not properly getting the care for diabetes. This is a recent statistics in 2024, slightly alarming. Of those receiving treatment for diabetes, only 15.7 have control over their glucose. Of course, many of us are aware of these limitations in our own country, but despite all our efforts, only 15.7% is having control over their diabetes. So let me share with you, and that is the intention of my oration, Let me share with you, with all humbleness, a couple of success stories from Kerala where this 15.7% is replaced by 86% success. And this all started with probably one of my own personal experiences, my own personal disappointments. As a young boy, my father got admitted with diabetes complications when I was in the 7th grade in my school. And he didn't survive much. I lost him when I was still young. But I somehow procured a glucose meter for my mother. My mother was also diagnosed with diabetes soon after I was born, and this was in early 1990s. It is still with me. The AIMS reflectance glucose meter, which is part of history of technologies in diabetes. And this is a recent picture. Of course, my mother is having Parkinsonism and associated disabilities, but she hasn't developed retinopathy or neuropathy or nephropathy. No complications due to diabetes, and she is currently 85 years old. Thank you very much. And maybe from my personal experiences of treating my own family, when I started practicing, I introduced a telemedicine program way back in 1997. And over the years, we were improving upon in our project and in my programs, and we incorporated electronic medical records, multidisciplinary team, and the program was very simple. And this is one example of a lady, 66-year-old, whom I met first in the year 2008 with a baseline hemoglobin A1C of 8.7%. And this lady was willing to get enrolled in the DTMS telemedicine program. Consent is required, so that they will be measuring multiple glucose values, and these are on specified days, minimum 4 values, fasting, and 2 hours after all the 3 major meals. And once the titration is optimized, maybe after a month or maybe after 3 months, then the frequency is again customized. It could be once in every 2 weeks or so, 2 or 3 times a month. And this is over the last many years. And this is a screenshot from the electronic medical records on how the hemoglobin A1C has been maintained below 7%, and how the average postprandials after breakfast, lunch and dinner is maintained below 140 milligrams per deciliter. So it is doable. And telemedicine, of course, we were all reinventing and practicing telemedicine during the COVID pandemic. And telemedicine is not at all a rocket science, and it is a doable practice even in low middle income countries, and it requires very limited resources, especially from the patient front. And during every teleconsultation in our program, it is again an opportunity to administer an educational module. And this is again personalized, and this could be for the management of hypo or for troubleshooting on the use of a device or on insulin injection techniques and so on. And during every telemedicine consultation, not only the screen is shared, we'll be discussing the pattern, and this could be on creatinine or LDL over the last many years, and the people with diabetes feel very comfortable, very convenient from their own houses. And this is again with a multidisciplinary team, and it is not the doctor alone being part of the telemedicine consultations. And I'm so happy to share with you that recently we got an invitation from the World Health Organization, and we prepared a manual, a very detailed manual for the World Health Organization. And this is a training manual not only for diabetes but also for hypertension, how this can be managed via a telemedicine program. In modern medicine, it is very important, it is critical to generate evidence, because you need evidence to establish and to adopt either treatments or technologies. And over the years, we were in the forefront, publishing papers and generating the evidence. And this is not only for hemoglobin A1C reduction, but also in even preventing the progression of chronic kidney disease in diabetes, lowering A1C, blood pressure and other parameters in diabetes. And this is one paper where we have unraveled all the secrecy of telemedicine. And this has been acknowledged by many recent app developers, the mobile health application developers, the limitations of use of telemedicine, the challenges in the use of telemedicine despite the evidence and despite the success stories. And this is, the first author is Rebecca Vitale, who was on a sabbatical with us for a few months. She came from Yale University in the United States. And when she was working with us, she compared two of our centers. In one center, we were having a conventional diabetes management. Patients were coming to the hospital, getting a prescription, and they will come back after a week or come back after a month or come back after every 3 months. We'll have some lab investigations. Whereas in the telemedicine center, the people with diabetes were having frequent teleconsultations in addition to 2 or 3 consultations, physical consultations every year. And she published this paper, and this is demonstrating huge differences between the two centers. The telemedicine center having significant improvements in the hemoglobin A1C and multiple other parameters. And in another paper, and this is with 1,000 patients with type 2 diabetes, we could prove with telemedicine and structured SMPG. The terminology is very, very important. With structured SMPG, and when you are capable of training and empowering your people with diabetes, with a hemoglobin A1C at baseline of 8.7, and this is at 3 months, and this is at the end of 6 months, we were able to bring it even below 6.5%. And that too without any episodes of a serious or a symptomatic hypoglycemia. So telemedicine and structured SMPG, when you are incorporating within your conventional diabetes care, significantly reduces the cost of diabetes care, significantly reduces the complications and the burden in the future. And this is a paper along with Dr. Mohan. Telemedicine increasingly being utilized in the care of diabetes people to improve the quality of care and also to improve the psychosocial outcomes. During the COVID pandemic, for those who were already trained in telemedicine, more than 1,200 subjects, we were even having interventions at home for COVID management. And we published this paper in detail with an intention so that this can be considered as a model in case there are similar pandemics in future. And this is a paper in International Journal of Diabetes and Technology, and this is long-term impact of telemedicine. When compared to conventional care, huge reduction in not only hemoglobin A1C. The question is, what about the overall quality of care? For all the domains tested against conventional care, mobility, self-care, usual activities, pain, discomfort, anxiety and depression, there were significant differences between the two models. And this is last year at the American Diabetes Convention, when we compared the two modalities. The treatment group, when compared against conventional care group, there was almost 50% lesser proportion of complications, and those which were significant. And this is a waterfall plot clearly demonstrating the differences in the occurrence of neuropathy, coronary artery disease, CVD, retinopathy, and even chronic liver disease. All of these were statistically significantly different. And what about incorporating the paramedical stuff? And that is again mandatory. We as doctors alone cannot implement telemedicine in diabetes care. And this is one study, not from India, and the enhanced study. It increases the chances of drug adherence. And it also helps in optimizing the diabetes care. Not only improving the glycemic outcomes, but also non-glycemic outcomes. When during every teleconsultation, when you are also having an opportunity for diabetes education, it enhances empowerment and also improves diabetes and health literacy. Let me also take this opportunity to invite all of you, and I I'm aware that all of you are aware of this World Congress. This is the biggest conference for technologies in diabetes in our country. And the registration is closing today, between 9th and 11th of May at Jaipur. Telemedicine also involves remote monitoring. Remote monitoring is in fact an integral component of telemedicine. And almost all of us are already leveraging remote monitoring with these devices which are very popular, and these are the connected glucose meters. And even the My Sugar, currently there is a option for having the data in the cloud with AccuCheck Connect. And Libre and LibreView, I am sure most of you are used to continuous glucose monitoring and then having the LibreView, and this should be, as a rule, part of the workflow in your clinic and hospital. This should be as part of the workflow in the hospital. And this is with an example from our own hospital. This is a child who gets admitted for automated insulin delivery, that is 780G. And as a rule, beyond 4 days of admission, the children, the parents, the caretakers and the multidisciplinary team will be there in the WhatsApp in a dedicated group, at least for 3 months, so that the care is getting optimized and the people who are in the group will be trained on even managing the emergencies, not only for routine titration, not only to make sure that they are reaching almost 100% time in range, eliminating almost completely the time below range with the newer generation of automated insulin delivery devices, but even troubleshooting. And this is a cannula change via the video. What about the challenges of telemedicine in routine diabetes care? I am pretty sure that all of you are aware of the multiple challenges in telemedicine care, but this part is vital. Are we compensated? And is it considered equivalent to a physical consultation or not? And if you are maintaining high quality devices and the softwares, it is going to be an expensive process, especially when the data need to be stored for research, and the tendency for elderly patients to extend the conversations beyond the limit. But the future appears to be very bright for telemedicine. And this is a prediction. Look at the global market. And this is the compound annual growth rate, which is predicted at 10.65. And this is the estimate in 2022. And this is the anticipated estimate in 2028. So appears to be very bright. And probably the diabetes practice in future is going to be a hybrid care model, where you'll be integrating AI into the electronic medical records, similar to adding a little bit of salt onto the dishes, which can transform the taste and the flavor. You'll be adding a little bit of your AI and the algorithms onto the existing electronic medical records. The AI-driven tools can proactively flag those patients at risk, and the patients can share the vital signs. And nowadays it is a practice for many of us to look into the data in the mobile phone, especially if the patients are having a wearable sensor, for example an Apple Watch, to look into the data on the sleep, the resting heart rate, the physical activity details. And why not? The same data is available in the cloud, and the data is shared or integrated with the electronic medical records. And again an invitation, and this is the 13th year of the JPF convention in Trivandrum, and this time we are having Tade Batilno, and Tade is the founder of ATTD and the scientist who coined the term time in range. And all these researchers are going to be physically present in Trivandrum, and welcome all of you. And AI can completely transform, especially when it is closely incorporated into a dynamic EMR system. The AI can track the possibilities of a severe hyperglycemia, and it can promptly alert a diabetes nurse or educator to call back the patient in time. Of course, telemedicine cannot be used for emergencies, but telemedicine can be utilized for preventing an emergency. And this is an upcoming continuous glucose monitoring device already available in 3 countries in Europe from Roche family. And this is meant for remote monitoring, and this is a continuous glucose monitoring sensor with artificial intelligence integrated. And that is ML algorithm and a tree algorithm, meant for 2 predictions and 1 forecast. It predicts hypoglycemia within the next 30 minutes. It can forecast glucose within the next 2 hours, both hypo and hyper. And it can estimate the risk of hypoglycemia overnight. For example, you can have a look at the predict app. There are 2 different apps. One is the CGM app and the other is the predict app. So soon before going to the sleep, you can have a look at the predict app, and it will give a prediction on the chances of a hypoglycemia with almost a 99% accuracy. And these are all upcoming devices promising remote monitoring and virtual diabetes practice. And this is our dream, to have the scientific organizations such as the RSSDA, ADA and the authorities to officially recognize telemedicine, since we have evidence of improving and promising high quality outcome, preventing the complications and burden in diabetes, provided there is a fair pay which is ensured for the doctors, the paramedical staff and also for the hospitals. And this is our vision and the ultimate dream, telemedicine to be incorporated in routine diabetes care considering the robust prevailing evidence. And now the biggest diabetes convention. And I welcome all of you to Kochi in Kerala. And after 14 years, we are organizing RSSDI in Kerala, the 53rd annual conference between 6th and 9th of November 2025. And again, back to my dear friend Pratap Jothydev for this opportunity. And my heartfelt thanks to him once again. And this is Jothydev in the year 2018, remember? In JPF. And I am so happy that he comes to JPF, to Kerala almost every year. And this is a very recent picture, along with Dr. N.K. Singh, when we were having the similar RSSD Kerala chapter annual meeting in the month of February. And thank you all my friends at RSSD Gujarat chapter, our dear friend Sajay Phatak, my dear Dr. Rudal, Pratap again, Akash, Kamaldeep, Parak Rana, BK Soni, Dishak Patel. Once again, thank you very much, my dear friends, for this honor and also for your patience in hearing me. Thank you very much.